Great, thank you. I was talking on mute. Thank you. I appreciate that.
Thank
I said
you.
I was going to go ahead and turn the recording on, and I'm glad you pointed out I wasn't even off mute. So my name is Katina Flagg. I will be your facilitator for this live lecture. We do have two of them every term. This is the first one, and then the second one will be coming in next few weeks. But these sessions are really designed with you in mind. Right now, I'm going ahead and start with the camera on, but in just a second, I'll go ahead and turn the camera off. I am working on one monitor today. So please, if you have any comments or you want to add commentary, please unmute your mic, as I will not be manning the chat box. But this is an opportunity for you to be engaged, for you to ask any questions, make comments. If you have any examples that you like to pull in from your prior experience, that will be welcomed as well. So again, Katina Flagg, your facilitator. I will be turning off my camera now, and I will go ahead and go into the lecture. But before I do that, does anyone have questions, comments, or concerns?
No, I do not.
Great, thank you. No questions about the assignments, about APA formatting, your activity and discussions. Just wanted, if you had anything, just know that we're here to support you. That's another reason why we host these sessions as well, so that y'all can know that there are really people in your classes and that you are dealing with people and not robots, right?
I did have one quick question. Are the slide deck, is that going to be available to download later on, or is that going to be available in the chat here somewhere? I know you're recording, but
Yeah. I mean, we don't generally send them out, but I can. It doesn't hurt.
Okay.
Yeah, we can make it available.
Thank you.
We will be sending out as well, Eric, good question. We'll be sending out a survey link. Unfortunately, I cannot find the QR code right now. I don't know where I saved it or what I saved it under, but that's okay. I'll get that to you as soon as I get this slide deck out. Aging gracefully, and sometimes you just forget some things, and I guess that's just one thing and my program director, Dean, she said, please don't forget to send the link. And I'm like, okay. And then I went to look for it, and I don't even know what I saved it under. So I will get that to you all as soon as we're done. I'll go find it and get it out. But hopefully you guys find these, hopefully you find these sessions informative. I mean, they're really brief. It's not a lot of time, but at least we can connect, and you know that we're here for you, right? If you have questions that I'm not able to answer, you can reach out to your instructors at any time, or you do have my information, you can reach out to me as well. All right, so remember, I'm not manning the chat box, so I will go ahead and jump over to the slide deck. So when we look at introductions to claims processing, so I don't know how many of you may work in the revenue cycle, but the claims processing is a heavy part of the rev cycle, and it's a very important part because that's how organizations are paid. So if you know anything about the hospitals, every hospital needs money. And the CMS guidelines and all of these payers have really been really lean. They want us to provide quality services at the most economical cost, and there's a lot of rules and regs into that. Understanding the 10 steps to the medical billing claims process and a rev cycle is going to be very advantageous no matter where you work in an organization. Everyone has something to do with revenue coming into the door, right? If you work in a facility, as fast as you get the patient schedule, that's tied to processing these claims, right? So these are some of the common objectives here. You will, if you work in a doctor's office or ambulatory treatment facility, how you bill your claims will be on the CMS 1500 form. But if you actually work for the hospital and the patients are admitted, they have day stays like in the ICU or whatever, there's a UBO form. And that's where it's an itemized claim. So these are the two claims forms. Many years ago, when I was in the hospital or working for release of information copy services, we had to complete these forms on hard copy paper. They're now completed electronically. Due to, regulatory requirements, the financial relationships, there should not be any kickbacks. That's a physician violation. So there should not be any kickbacks where the providers get paid to perform a service. The providers, they've really restricted those relationships with the pharmaceutical sales companies. The pharmaceutical sales used to go in those hospitals and spend a lot of money on meals and, you know, whining and dining the physicians to get them to, use their drugs. Well, all of the pharmaceutical sales reps still um, go out and market their drugs, but there's guidelines on that. Any questions or comments? Okay. So when you look at retrospective, before the creation of Medicare and Medicaid in the 60s, providers billed their patients directly. We really didn't have, HMOs and PPOs. You had your commercial health plans, or you had the providers that provided services and they got paid for their services. But as time progressed, we do have our commercial payers, and then we have our governmental payers, which Medicare and Medicaid, or our military health plans, right? When we look at the history of the reimbursement, the prospective payments, we are currently in a prospective model. This model allows the third party payers to know what is going to be billed in advance, realize cost savings, and promote cost sharing types of organizations. We have our managed care, we have Medicare, and we have Medicaid. So when we look at the providers know what's going to be billed in advance, right? That's because we have to get prior authorizations. Before, you did not have to get prior authorizations, but the hospitals and the insurance companies kind of work hand in hand together. You have to get that prior authorization, so the insurance companies give you permission to go ahead and perform those procedures, because that reduces the denials. Now, after they give you permission, you could still get a denial, but the denial may be based on documentation gaps versus procedure gaps, right? If a patient has a particular diagnosis, and for instance, now diabetes, right? So diabetes, we know right now that everyone is looking for Ozempic or Manjaro, and those are the medications that are used to treat diabetes. But these drugs also has a significant impact on weight loss, right? So before a prescription can be prescribed for those drugs, you have to get approval from the insurance companies to pay, because they're over $1,000 a month. So that's where you know what is going on with the patient. Well, yeah, the patient may qualify for Manjaro, they may qualify for Ozempic, but the insurance company may deny it and say, we want to try a less invasive approach. Let's put them on this oral medication. Let's try them on this other drug first. If those drugs do not work and maintain that patient's quality of health, then they titrate up to the more expensive drug. So that's some of the things that you see happening when they, looking at that cost sharing, looking at that managed care. Does that make sense to everyone?
Yes.
Yep.
Any questions or comments about that?
Nope.
No, I'm sorry.
No, I was gonna ask a question, but I understand.
No, go ahead, Lawana. Ask your question, please.
Okay, so like I had like this is on the personal. This is like something that happened to me. I had a prescription that was supposed to be filled, and like um they couldn't fill it because the doctor or the insurance wouldn't allow it to be filled, so the doctor had to go back and change whatever the prescription was. So what they should, and this is kind of weird because what they suggested was more what the doctor was trying to give me cost less than what they wanted me to have.
So they made a different recommendation, and you don't understand why they would say, instead of giving you drug A that was more reasonable, they wanted to put you on drug B that was more expensive. But when they wanted to offer you drug B, was it a higher out of pocket cost for you? What was so when they look at the performance of the drugs, although A was probably a little bit less expensive, A may not have given the outcomes for your quality of life versus B. Or there could have been a shortage of drug A, and that's why they're recommending drug B.
Okay. Yeah, it was some eardrops, and they were like, wanted me to have the other than versus the, and that one cost higher. So
Yeah.
it was kind of weird, and I just didn't understand it.
And
So now I
sometimes, yeah, sometimes the performance could be the long-term impact, I'm just gonna say I'm throwing anything out there.
sorry about
Somebody,
that.
okay. So it
Sorry.
could be that you had an infection. I'm just throwing something out there. I don't need you to validate this or not. But you could have had an infection. And the infection and your white blood cell counts could have been so much higher. They knew that they needed to treat you with a stronger drug. So they just went ahead and put you on the drug, and you'd be on that drug a shorter time period than you would have had to be on the longer, product A. So
Okay.
those are some of the things that they look at on the backside. And that's why the insurance companies are made aware of
Mhm.
what's going on. Will someone mute their mic, please? What's going on with the patients and have that communication ahead of time.
Right.
Eric, did you have a comment?
No, I don't. Sorry.
Okay. I just saw that you were off mute. Okay. So
No,
when we
my
look
dog
at
took it.
when we look at the providers, suppliers, and claims, so there are various types of providers. You have your hospitals, you have your critical access hospitals, you have your skilled nursing facilities, you have your outpatient rehab facilities, you have home health agencies, you have hospice and clinics. So these are not limited, but these are just some examples of different organizations that uh, you know are a part of the whole reimbursement revenue cycle process. When you look at your prospective payment systems, you know, did I go backwards?
Yeah.
No, I did. Okay. So then you have your sniff, you have these various, your durable medical equipment. So you have home infusion. Just like right now, some patients can actually get um, dialysis at home. Did you all know that they have home-based dialysis now where people can get their dialysis treatment while they sleep at night?
Yes.
Okay, versus going into the dialysis facility. Now, there's some people get approved for that dialysis and there's some that do not. Some people just don't want it. So then they have your various hospice. You have your hospice facilities versus you have home-based hospice. It depends on the type of insurance that you have. It depends on your coverage to determine if you could have home-based hospice, if you need to go to a hospice facility. So there's a lot of different um, criteria in there. So that relationship with the hospitals, that's why they have those case managers in place to communicate. The case managers and so are providing the insurance companies updates if you're in-house on what's going on with your status, you know, um, what type of changes in your health care happen so they could determine what's the best scope, what's the best treatment plan. So the
Hmm.
insurance companies and the hospitals are working side by side to provide the best quality care. Now, be mindful that it's human factors involved in all of these decisions. So they have, you know, humans involved. And so sometimes we're getting denied. We have to fight claims, and that's all a part of the process in the rev cycle. But having great documentation, having great strong policies, having streamlined approaches are instrumental in the success for any organization. Any organization.
Mm-hmm.
Any questions, comments, or concerns about anything this far? Okay. So when we look at your institutional claim, we talked about that being that UB04. You can look that claim form up. I don't have an example of one right now, but look at the difference between the CMS 1500 form and the UB04. The professional claim form is that CMS 1500. That's considered our outpatient claim form. Both of these forms are now electronic. Most hospital systems are either on Cerner or Epic. If they're not on Cerner or Epic, they're probably a smaller facility and they're using something like a McKesson product. But every last one of these organizations can submit these claims electronically utilizing these ANSI 837 transactions to align with the HIPAA mandated transaction set. These are secure platforms to send that clinical data back and forth. And it doesn't matter what organization you go to, they're going to all use the same CMS 1500 form or the same UB04 form. Does that make sense?
You say they use
UB Uniform Bill. UB04 is called the Uniform Bill 04. And then
Okay.
the CMS 1500 form is a Centers for Medicare and Medicaid Services. The form is number is 1500.
Okay.
Okay. The UB04, the form number is 4. Uniform Bill.
Okay.
Oh, there's a copy of the CMS 1500 form, right? So when you look at lines 1 through 13, we call all of that the patient information. That's where the demographics are going to go. That's where we're going to have your address, the type of insurance you have, if it was a workers' compensation claim. And then boxes 14 through 33, we call that the provider information. You see it's a black line that separates that form. And everything after that black line is going to have like your data services, your diagnosis and procedure codes, any modifiers, the provider's national provider identification number, their NPI. If it's a Medicare patient, if you look on line 27, it's going to say accept assignment of benefits. That means that the organization or the provider is going to accept the Medicare contractual negotiated rate, that they will not charge the patient the difference. That is fraud if they try to charge the patient the difference. Okay? Any questions or comments pertaining to that information?
Nope.
Awesome. Okay, keep it moving. We only have a few minutes left, 10 minutes, and we'll keep it going. If I can get the screen to advance, there we go. So these are just the back side of the form. And then when you look at your UB04, that's your uniform bill. There's a total of 81 sections on this form. It contains the patient demographics, the provider information, the federal tax ID, and the NPI, the National Provider Identification Number. That's a number that doesn't change. As you see, it says national for a reason. No matter where the provider go to work, they will use that same number. As you can see the difference in the two forms. In this form, things are itemized, right? So if the patient has 3 pills, they're going to itemize the 3 pills on this form. If they stay in the ICU 14 days, it's going to be itemized on this form. If they stay, if they have a trach, that trach is going to be itemized on this form, because this is the hospital claim form versus this is the outpatient claim form. Okay, so if they have to do something times 5, it'll be your modifier, and all of those different things will be on here. So those are the 2 different claim forms, one for outpatient services, one for inpatient services. Does that make sense to everyone?
Yes.
Okay. So when you look at those service codes, you do have your revenue codes. Thanks, Eric, for that thumbs up. You have your description of your services and your HCPCS codes, your Healthcare Common Procedural Coding System. That's that 3rd book, right? So you have your procedure codes, you have your diagnosis codes, and you have your HCPCS codes. Your durable medical equipment comes out of here, those crutches, wheelchairs, porta potties. Those are things that you build out of your HCPCS codes. When you look at your payer information on these claim forms, you have your third-party payers and you have your governmental payers. You have your health plan identification numbers. So that's how they identify. That's the contract down to the patient level. So remember, if you have a third-party payer, Blue Cross Blue Shield, that's the global contract. How the individualized contract get down to the patient, that's your health plan identification number. Because you and I can work at the same organization, but you may have a HMO and I may have a PPO. That delineates the difference between our contracts. So that's why they always reference your contract number, because your benefits are different. Your out-of-pocket expense are different. So people need different things based on their family and their financial contributions. Any questions, comments, or concerns?
Yeah, I got a question.
Sure.
So if you have a HMO, you have to go to the doctors that are in that particular
Group.
group. So with a PPO, you choose your own doctors.
Yeah, you have a little bit more flexibility. Like for me, I've always had very, very bad allergies, so I never select an HMO, because if I get sick, I don't want to have to wait and go to my
Yeah.
primary care physician, and then my primary care physician send me to my allergist. So back in the day when I started selecting PPO, there used to be like a 14-day referral period because everything was done so manually. And I was like, oh no, I could suffer for 14 days waiting for them to approve my authorization to go to my
Mm-hmm.
my allergist. So that's why I select PPO every single time. But that's my rationale, right? Some people may have a different reason for selecting the HMO. They may say, I never get sick, so I don't want to pay the extra money for a PPO. I only go to the doctor once a year for my annual exam, so I'm perfectly okay with an HMO. So it just depends on people's health status and financial contributions to determine what best works for them.
Okay.
All right. Any questions or comments? So when you look at the diagnosis codes, like the admitting diagnosis, why did the patient come here? What's wrong with the patient, right? The reason for their admission. So these are the principal and procedure diagnosis codes. Those are captured on, and we're still talking about your UBO4, okay? We're still talking about the UBO4 form. These are your inpatient stays. That's why you see the term called admitting. When you look at an outpatient stay, it's no admitting because they're not being admitted for several days. They have a visit type, okay? So understand the difference in your language as well when you're talking about an inpatient admission versus an outpatient ambulatory stay. Visit, okay?
Mm-hmm.
So when you look at the sections of your CMS 1500 form, you know, now we shifted again, the way the slides are set up. They're coming back over here talking about the CMS 1500 form. The types of insurance carriers, you have your Medicare, you have Medicaid, TRICARE, CHAMPA, Group Health Plan, FICA, Black Lung, and other. So other could be workers' compensation, okay? Because we do have stakeholders injured and they have workers' compensation plans. It's a state law, in Texas, you have 3 employees, you got to have workers' compensation. So some organizations did not go with I'm going to say Texas because I'm in Texas, but the Texas Workers' Compensation Plan, if they had a large enough organization and they can create a plan that replicates the Workers' Compensation Plan, it's legal to do so. When I used to work for the facility, it was an HCA facility. They were a very large company. They created their own workers' compensation, meaning that we had to go to their doctors first. We had a guideline. If you got injured at work, you had to report it before you left. You had to start your claim before you left. If you went home and came back, then you were out of luck because that was their rule. But it was very equivalent to workers' compensation. The another thing with their rules were um, you had to exhaust your own PTO. If you didn't have any PTO, you didn't get paid. So there was a lot of things that happened into that, but it was equivalent and it was relevant and it works. And then if you had short-term disability, long-term disability, so basically they offered the product, but you had to really secure yourself financially. If you were one of those employees that burn up all of your time and you got injured at work, you kind of in trouble. So you
Yeah.
just have to be mindful of that when you become gainfully employed with companies. When they're going through that HR process, you really need to listen to those benefits. Luana, did you want to make a comment?
Oh, I was just saying, yeah, because uh, going through my own insurance and I moved from New Mexico to here to Tennessee, and going through my insurances and stuff. Um, and the first year I had, I got the insurance, and then we did the enrollment, and it's like it seemed like something changed. I thought something changed because now I have a situation where I have to um, deal with it now when it comes to the claims.
Yeah. And Luana, something could have changed, right? Let me tell you. The organizations that you work for, when it's time for them to renew their contracts with these payers, they go back in and renegotiate those contracts. So that's why when it becomes open enrollment period, it's very important to look at your benefits and
Hmm.
not just default, because something could have significantly changed. You could have had an HMO plan and your out of pocket could have changed. They could have taken it from a straight HMO to a POS. A POS is an HMO, but it functions like a PPO. So those are some of the things that you all need to evaluate when you're looking at these claims and how claims are processed. Does that make sense to everyone?
Yes. Well, yes.
All right. So we are winding down. Oops, sorry. I forgot I had my tank top on. I too. Um, we're winding down. Do y'all have any questions or comments for me?
Well, I
Nothing?
enjoyed. I enjoyed it. This make me this made me understand a little bit better of the processes, especially with my own situation. And basically, this is something that everybody is going through and everybody needs right now. And then you know, and going into it, it seems a good thing.
Oh, thank you. Thank you. Maria?
Uh, yeah, I just have. Could you kind of, I guess, briefly kind of go over the white paper? I just kind of was like trying to understand it, and it kind of confused me.
Yeah, totally. So when you look at your resources for the white paper, this is really used in healthcare. Um, and if you go under your reading resources for week 3, it tells us there's a document here, how to write a white paper. And hold on, let me go back and flip to that because oftentimes students struggle with that, and we really worked hard to try and embed these resources for you. So when you go to your reading resources, you'll see you have your PDF, you have your landscape here, then you have this document, how to write a white paper. And it gives you the breakdown of to help you. So, it tells you what a white paper is. And generally, that's where the gap is. A lot of stake, and I'm not saying this to be you, but a lot of people don't really understand because they never heard of a white paper before. But a white paper is a deeply informative report used to educate an audience on a specific position or to propose a solution to a problem. It is thoroughly researched using all of your scholarly resources to help you develop your white paper. So when I had to write a white paper, I did it on a professional level at MD Anderson when I was there in management. And oh my God, I was stressing out because I had never had to do it. It wasn't introduced to me in college. And so it was a new concept. We had to, it was a project we were working on, and we had to do the proposal, and it was going to our senior vice presidents. So what you're doing is you're actually finding a topic you're going to research, and then you're going to basically sell that product, or you're going to identify what the gaps are and propose solutions, right? So the purpose is to enhance whatever it is in your industry. You're going to present your research, and then you're going to promote the advantages or disadvantages, and or once you identify your company, right? So then you have your overview. Then you're going to do your comparison and your list. So then these are the various types of components. You can use tables and graphs. You can do have your subheadings, and you must have citations in your white paper. So it's basically a big comprehensive, I don't want to say research paper, but it is a research type of paper, but you're also proposing a solution in this as well, right?
Mm-hmm.
So you're going to generate your topic, you're going to get your credible resources, you're going to use your formal writing, and you're going to, document that thing. And I think here we may have attached a template before. Yep, but so the audience is important. Let me see. I thought we added an example. First thing is a moving. You see, it's just okay. Let me see.
Mm-hmm.
It was giving me the blues. Okay, so if you go under module one, you see we even have more content. We gave you examples and everything. Sweet, huh? I see that heart. Yeah. So you have a little library. We tried to, spell it out for you as well as we could there. So there's readings, there's content there to help you, and examples of a white paper.
Okay.
Thank you.
I know
You're welcome.
I printed off a it's like a presentation. I had I don't know if this will help anybody, but I printed it off, and it's called a white paper guide, and it has owl on it.
Yeah, I mean, if you want, you could share it with your team members. You could drop it in the chat box. Yeah.
Yeah, if that helps anyone, because that's what I printed it off, and that's what I'm gonna try to use, because it seems like it's really, it takes you step by step from what I can see on it. So if that would help anybody, it's called White Paper Guide, and it has OWL, and it's like a presentation, like a PowerPoint.
Yeah. And yeah, you can look for resources too, but we do have enough stuff that's embedded. I mean, you can use anything extra. We welcome that, but just make sure that we follow the rubric as well and you cover the content that's in that rubric as well.
No, I got this. I got this off of one of the lists that were on the
Yeah.
that you just showed. That's where I
Yes.
got that from.
Yes. Okay, that's perfect. Perfect. Well, I want to say thank you all for joining the session. Hopefully, you found this information helpful. I will be sending out the survey link. Unfortunately, I just could not find it today before. I don't know where I saved it, but thank you for joining and look forward to seeing you next time. Have a great day. Bye.
Thank
Thank
you.
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 Thank you.